Welcome to the presentation on ultrasound evaluation for abdominal aortic aneurysm. I have no disclosures to report. The objectives of this presentation are to review the basics of aortic aneurysm. We'll review the ultrasound technique for the identification of aortic pathology, both aortic aneurysm, and a little bit on aortic dissection. We'll review the pearls and pitfalls to consider when scanning for aortic pathology, and hopefully by the end of this presentation, you'll be capable of rapidly identifying aortic pathology with point-of-care ultrasound. Well, first let's talk about some of the basics of abdominal aortic aneurysm. It affects 5 to 9% of the population greater than 65 years of age. And there's three main types. At the top of your screen, you can see a representation of a normal aorta. And it's intended to indicate the three different layers with the intimal layer, the tunica media, and the adventitial layer. Now, first off, let's discuss the most common type, which is a fusiform aortic aneurysm. And the hallmark of the fusiform aortic aneurysm is it involves all three layers and their circumferential involvement. In other words, fusiform dilation of the affected segment of the aorta. Then there's the saccular aneurysm, where you can see here just one side of the aorta is affected, and that side of the aorta has a ballooning feature to it. Take note that all three layers are involved, the intima, the media, and the adventitia. Whereas a pseudoaneurysm, it looks similar to a saccular aneurysm as a focal ballooning segment of the artery. However, only the adventitia is involved in the wall of the aneurysm. The intima and the media are effectively disrupted and not ballooned out into the aneurysm and not making up a part of the wall of the aneurysm, whereas the saccular aneurysm, you can see that the intima and the media are involved. In the case of the pseudoaneurysm, usually there's some kind of component of trauma in the patient's past. For example, the patient got a cardiac catheterization or they had a arterial line placed. There was a disruption of the intima and media, however the adventitia remains intact. And this adventitia begins to balloon as blood from the lumen spills into the adventitial layer. Now, the mortality of a ruptured aortic aneurysm is quite high, with an overall mortality of 90%. 50% of the patients die before hospital presentation. Of those that actually make it to surgery, mortality is an additional 50%. So, rapid diagnosis and disposition is critical. So why would we use bedside ultrasound? Well, fewer than 25% of patients know they have the illness. Only 25% present with the classic triad, that is hypotension, back pain, and a pulsatile mass, something that we were all taught in medical school. Using exam alone, AAA is misdiagnosed 30 to 60% of the time. The most common complaints, if you look through the literature, show that abdominal pain is present 76 to 83% of the time. Back pain is present 54 to 61% of the time. Both very non-specific presentations and something that we all commonly see in our day-to-day work. Now, physical signs of shock is present only 66% of the time. Systolic blood pressure less than 110 or positive orthostatic vital signs 48% of the time. Systolic blood pressure less than 90, present only 13% of the time, and syncope as a part of the presenting complaint is only present 29% of the time. So I think those are some very sobering statistics. And I hope that you remember that the most common presentation with ruptured AAA is actually abdominal pain and back pain, things that we see commonly, things that are very nonspecific. Whereas the classic presentation of ruptured AAA is present quite infrequently, and I hope that you resist the temptation to rule out the diagnosis of ruptured AAA because your patient does not have hypotension, syncope, or signs of shock. With the use of ultrasound, we have a high sensitivity test, greater than 90%, sometimes up to 100%, depending upon what studies you're looking at. It's very easy to perform, and it's non-invasive. And in studies looking at the time to definitive repair in patients who had ruptured AAA, comparing those who got point-of-care ultrasound versus those who did not get point-of-care ultrasound, you can see the time to OR was 83 minutes with point-of-care ultrasound, whereas those who did not get point-of-care ultrasound, their time to OR was 182 minutes. So we have a high mortality, time-dependent illness that has a non-specific presentation, and we have a study that has a high sensitivity. It's very easy to perform, it's non-invasive, and it's a rapid test that can cut your time to definitive care in half. All good reasons to bring a point-of-care ultrasound to the bedside early in any patient you're considering who may have the diagnosis of rupture AAA. So what defines a AAA? Well, that's a focal dilation of the abdominal aorta at least 50% or 1.5 times its normal diameter. The number that most people cite will be 3 centimeters, and that comes from this study right here, Journal of Vascular Surgery, 1991, where they actually looked at the average diameter of the 3 segments of the abdominal aorta in both males and females. And you can see the average diameters at the supraciliac, suprarenal, and infrarenal portions of the aorta. And for the most part, the 3 centimeter cutoff for aneurysm works quite well, with the exception of maybe the supraciliac portion of the male aorta, which is a rare location for abdominal aortic aneurysm. So it's okay to use this 3 centimeter cutoff. I would like to call your attention to the common iliac arteries. Now, isolated common iliac artery aneurysm is quite rare, occurring only 2% of abdominal aneurysms. However, it does coexist with abdominal aortic aneurysm 20 to 30% of the time. So when you do find a AAA, and assuming the patient is stable, I think it's worthwhile to scan down on the common iliac arteries and make sure they're not dilated. And here you can see clearly the 3 centimeter cutoff does not apply. You can see here 1.8 and 1.5 centimeters. I think the easy number to remember is just half of the 3 centimeters. We'll call 1.5 centimeter common iliac artery diameter as aneurysmal. This is important because this narrow vessel is going to be more likely to rupture, and it may create some urgency on vascular repair if you do identify this. Now, this is all, of course, assuming that the patient is stable. If the patient is unstable and it is clinically clear that the patient has a ruptured AAA, obviously trying to spend time to see if the common iliac artery is also dilated is not really doing the patient, nor the vascular surgeon, nor yourself any favor. Let's talk a little bit about the risk of AAA rupture. Now, obviously, size and rate of growth are very important factors when it comes to the risk of a ruptured AAA. We're going to talk more about that in a minute. But some other less common talked about risk factors for rupture of AAA. The number of people in the patient's family that have had AAA. The more there are, the more likely this patient may actually develop a ruptured AAA, not just the development of a AAA. And also patient characteristics. So heavy smokers with hypertension and female patients are more likely to have a ruptured AAA. And then, of course, there's the shape. The eccentric has kind of a serpiginous type appearance to it, which we're really not talking about the eccentric AAA today. But just understand that that type of AAA is more likely to rupture than the more classic common type, the fusiform. And you believe also that the saccular aneurysm is more likely to rupture than the fusiform. Now, with regards to size and likelihood of rupture, you can see this chart here showing that a AAA that ranges 3 to 4 centimeters has a 0% rupture rate in the first year. Once you go to 4 to 5.5 centimeters, there's a 1% 1-year rupture rate. Now, as you expand up to 5.5 to 6 centimeters, you see a 9% annual rupture rate. And this is why you often hear 5.5 centimeters cited as a size at which a vascular surgeon would elect to repair that AAA. And the reason for this, quite simply, is that a 9% rupture risk is a little bit higher than the percent of morbidity and mortality associated with open aortic aneurysm repair. So you can see that the benefits start to outweigh the risk of repair at this time. That's the reason that they don't repair at 4 to 5.5 centimeters. And then obviously greater than 7 centimeters, 32% annual rupture rate, which is obviously quite high. Now, the other big factor that has to be considered, and something that we're rarely going to know as acute care providers, is the rate of growth. Now, you can see here that the growth rate is highly variable. 20% of AAAs will actually plateau off and quit expanding, whereas 20% will expand greater than 5 millimeters per year, meaning approximately 60% will expand less than 5 millimeters a year. Also, the growth rate is not a constant. It actually is exponential. In other words, the larger the AAA gets, the quicker it grows. A growth rate that is high risk for rupture is greater than 6 millimeters per year. So if you're scanning a patient, discover a AAA, and they say that they have a history of AAA, it may be worthwhile to compare your measurements to their last CT or their last ultrasound measurement. If they're growing at a rate greater than 6 millimeters per year, you may want to give them some urgency to get back in touch with their vascular surgeon. Now, with regards to a ruptured AAA, 80% are going to rupture into the retroperitoneal space. So what this translates to is you won't necessarily have a positive fast exam. Now, where you would notice a positive fast exam is if the AAA actually ruptures into the peritoneal space. But the likelihood of you actually seeing this in a patient who's actually alive is quite low, because you lose that tamponade effect of the retroperitoneal space. If these patients rupture into the peritoneal space, they rapidly bleed out and oftentimes are not salvageable. So the take-home message here is that the FAST exam really has no role in the evaluation of abdominal aortic aneurysm. So let's start basic, and let's talk about how to actually get images of the aorta. Your probe selection most commonly is going to be the abdominal probe or curved linear probe. Now, if you were in a pinch and you didn't have access to the abdominal probe, you could use the phase array probe to do this exam, but honestly, the abdominal probe is the ideal probe to get the best images. Now, by convention, the probe indicator is going to be facing the patient's right, and you're going to start in the epigastrum just below the xiphoid process, and you'll be holding the probe in vertical position as shown here. Make sure you're not tilting the probe toward the head or towards the feet. I'll explain why you shouldn't do that in a minute. The patient should be in the supine position, and again, you're going to start off with the probe in a transverse plane with the probe facing to the patient's right. As you apply some firm pressure to mash the scan surface down into the skin, the key landmark that you're going to look for is the anterior cortex of the vertebral body here, indicated by this bright white or echogenic line, and behind that will be shadowing. The probe indicator is positioned on the left side of the screen, indicating that this is the right side of the patient's body. Remember, the probe indicator is pointing to the right. This will be the left-hand side of the patient's body. So we remember from basic anatomy that the aorta is located just to the patient's left of midline, whereas the inferior vena cava is just to the right of the patient's midline. Understanding that, we'll know that of these two black circles here, this is the aorta. Resist the temptation to rely on pulsatility to differentiate between the two, because depending upon the patient's volume status, both the aorta and the IVC are pulsatile. Yet another reason to always maintain your conventional probe orientation. Now, once you identify the aorta, the first thing you're going to do is the aortic sweep. And what I mean by that is a full sweep from the proximal aorta down through the bifurcation, just looking for any abnormal dilation. The reason for this is that the proximal aorta is deeper. Therefore, the proximal aorta is usually the most difficult segment of the aorta to identify. If you're spending 5 minutes trying to identify that segment of the aorta, and there's a AAA just above the bifurcation, which happens to be the easiest segment of the aorta to identify, and also the most common location for abdominal aortic aneurysm, if you identify a AAA just above the bifurcation, then you have the diagnosis and you can move on, rather than, again, spending a bunch of time at the proximal segment of the aorta looking for a AAA in a less common location, while a patient is exsanguinating from a AAA in a more common location. So just do a whole sweep of the aorta to make sure there's nothing obvious. Then you can come back and do your exact measurements. So let's see how that would look right here. Again, you can see they're starting with the probe located in the epigastric region just below the xiphoid. Here we see our spine shadow, aorta, and inferior vena cava, and they sweep all the way down through the aorta to the bifurcation, which we see right there. They'll come back up, and there they've done a sweep of the aorta, and we did not see any abnormal dilations. So now we could come back and do our routine measurements. Let's have a look one more time. Here's the spine with shadow. This must be the aorta. We're running down, making sure there's no obvious abnormal dilations. And we'll restart this one more time just to see as they place the probe in the superior portion of the abdomen. You can see initially the aorta is quite difficult to identify. So now that we've done a sweep of the aorta and we don't see any obvious dilations, we'll come back and make our specific measurements. And you're going to do this by dividing the aorta into 3 segments: the proximal, the middle, and the distal segments. Now, as I mentioned, the proximal segment is going to be the most difficult to visualize, and it can be identified as a region immediately around the celiac trunk. So your key landmark to identify the proximal segment is going to be the celiac trunk. And it also is going to be the largest diameter. Remember I said earlier that you can actually have a 3.9 centimeter proximal aorta and that be normal in the male patient. The middle segment, the key landmark for the middle segment is going to be the superior mesenteric artery. Once you identify the superior mesenteric artery, you know that you're immediately above the renal arteries. This is how you're going to know if the AAA is infrarenal or suprarenal. The renal arteries themselves are actually quite difficult to visualize with ultrasound. In fact, most of the time you're not going to see them. So not only is the superior mesenteric artery the landmark for the middle segment, it's also the landmark for the renal artery takeoff. Understand that 95% of AAAs are below the renals. Next, we're going to go to the distal segment, the most common location for abdominal aortic aneurysm. It's also, as I mentioned, the easiest segment to identify because it's the most superficial portion. Because the aorta is closer to the scan surface, it's intuitive that the aorta will be easier to see. But there is something that is less intuitive that also enhances your ability to see the aorta. And that is displacement of the bowel gas using the ultrasound probe to apply pressure to the abdominal wall and underlying small bowel. Visualization of the aorta is often limited by body habitus and bowel gas. With regards to bowel gas, because the aorta is more superficial in the distal segment, there is less room for the bowel gas to be displaced in a vertical position. So light pressures over the distal aorta is more likely to displace gas laterally, moving the gas out of the way so you can see the aorta. I think the best way to identify the distal segment is come all the way down to the bifurcation into the common iliac arteries, and once you identify that, sweep back up another 1 to 2 centimeters, and there's your distal segment. Lastly, as we mentioned earlier, 30 to 40% of AAAs extend into the iliac arteries, so if you do see a AAA, you may want to extend on down into the iliac arteries to make sure that it doesn't involve the iliac arteries. Remember, the iliac arteries are going to be more likely to rupture than the aorta itself if the iliac is involved. And also remember, your 3 centimeter rule does not apply with the iliac arteries. The common iliac artery is aneurysmal when it's greater than 1.5 centimeters. This next clip is just a brief basic anatomy review before we continue on.
As we place our probe on the abdomen, we can see several structures. The first structure to identify when identifying the aorta is to identify the spine. The spine is a hyperechoic structure in the deep part of the screen and has shadowing behind it. Once we identify the spine, we can identify the aorta and the IVC. Here we see the proximal aorta and the proximal IVC. As we slide down the abdomen, we see that the aorta becomes superficial in the abdomen due to the lordotic curve of the spine. Abdominal gas obscures some of the images of the aorta. However, with slow gentle pressure, the gas moves and the aorta becomes visible. As we start scanning the aorta, we can scan up and down in cross-sectional view. We start superior in the abdomen. Superior in the abdomen, we can see the branches of the aorta. The first branch is the celiac trunk, as we see here. Then the SMA. Splenic vein goes over top of the SMA. The renal vein goes below it. As we come down further, we can see no more branches of the aorta until we get to the bifurcation of the aorta into the iliacs.
So how are we going to measure? We're going to measure in the anterior to posterior direction, not side to side, and I'll explain that in a moment. And it's important to make sure that you have the gain adjusted properly. If you overgain the image, it's difficult to identify the borders of the aorta. And also, what I'll talk a little bit more about in a minute, make sure you measure in the transverse plane, not the sagittal plane, also known as the long axis plane. And the reason for that is to avoid something called cylinder tangent effect, and again, I'll explain that in a minute. Also really important to make sure that you measure with the probe oriented perpendicular to the vessel walls. And lastly, it's important to remember to measure outer wall to outer wall. This will allow you to include any mural thrombus in your aorta. And I'll show a demonstration of the right way and the wrong way to measure abdominal aortic aneurysm shortly. So let's start back at the top. You want to make sure that you measure in the anterior to posterior direction or posterior to anterior direction. Either way, just make sure that you're not measuring across the aorta. Remember from physics, there is an element of refraction of sound. So this sound is sent off into space and never actually returns to the ultrasound scan face. So what you get is a little bit of blurring on the edges. And here's a real image right here. It's a lot more easy to identify the anterior and posterior borders as opposed to the lateral borders. So you're going to get your most accurate measurements in the anterior posterior surface. If you look at a radiologist and when they do a formal aorta scan, they'll measure in all planes, but generally speaking, we recommend measuring just in the anterior posterior plane, and make sure that you have the gain adjusted properly. If you overgain this image, it will increase the blurring of the margins, and it can be difficult to tell exactly where the aortic wall begins and ends. And we talked earlier about similar to tangent effect, and that's a phenomenon that you can deal with when you try to measure the aorta in long axis. Now remember, when you go from transverse to long axis aorta, the image will go from a circular appearance to more of a cylinder appearance. And if the probe is positioned in long axis directly over the midline of the aorta, as is shown here in image A, then you would actually get an accurate measurement of the diameter. But the problem is in long axis, if you're slightly off the midline, and that can be quite difficult to tell from the long axis plane, as is shown right here in the B image, if you're measured just through the edge of the cylinder on your screen, the aorta is going to appear narrower than it actually is. So that's why we recommend not measuring in the long axis and just sticking to measurements in the transverse plane, because it's easier to identify the middle of the vessel. Also, making sure that your scan surface is perpendicular to the vessel wall. So if you look at image A and you're perpendicular to that vessel wall, it gives a nice circle appearance. Whereas if the probe is fanned slightly towards the head or slightly towards the feet, it's going to give a egg-shaped appearance, as you can see in the B example. You can see that that is going to actually produce a falsely enlarged aorta, giving kind of an egg-like appearance. Now, you'll recall I mentioned measuring outer wall to outer wall. Now, you can tell here this image is slightly overgained. It can be a little bit difficult to tell exactly where the aortic wall ends and begins. Now, you may have a temptation to measure right here, and you can see what we have is a 2.2 centimeter aortic lumen. And if you use the 3 centimeter rule, this patient doesn't have a AAA. But this is actually an appropriate measurement. What they should have done is measured like this, and this increases your measurement out to 6 centimeters. What we have right here is all mural thrombus. So a AAA does not consist just of the lumen, but the lumen plus the walls of the vessel, including the mural thrombus. Make sure that you carefully examine and identify the walls of the aorta. Here's an example of how to make your formal measurements of the aorta, largely for documentation purposes. Again, you're going to start with the probe in a transverse plane in the epigastrum, with the probe indicator pointing to the patient's right. You start off by identifying the anterior cortex of the vertebral body, and you will then notice an anechoic structure just to the patient's left of the midline. This is the aorta. Once you've identified this, you'll place your measurement. Here is the superior mesenteric artery. So this is our middle segment. Then last, we're going to go down to the bifurcation and then come back up another 1 to 2 centimeters. There's the bifurcation. So let's come back up and freeze the image and measure outer wall to outer wall. In this case, they didn't include the wall. I think they should have extended it out just a little bit, to be honest with you. This is obviously not a AAA. So let's look at that one more time. We see the aorta right here. Placing the calipers, come down. There's the SMA right here. Therefore, we know this is the middle segment. Get their measurement, and they'll come down. And looking for the bifurcation again. Once they identify the bifurcation, We'll come back up. There's the bifurcation. You can see the common iliacs right here. They come back up to measure the aorta. And this would be your distal segment measurement. Here's the IVC just for reference. Well, I mentioned earlier that bowel gas and body habitus are major limiting factors when it comes to ultrasound of the abdomen, and in particular, the abdominal aorta. Now you can see here that this image is greatly impeded by some overlying fatty tissue and then of course bowel gas down below. Now there's several areas here that I can imagine looks like the aorta, but obviously you can't tell definitively. But when you apply some pressure to this image and you squeeze the bowel gas off to the sides, you'll see the anterior cortex of the vertebral body, shadow behind it, and there's the abdominal aorta appearing as this gas displaces off to the sides. People usually when they're starting out are quite timid and don't apply much pressure at all on the patient. I promise you the patient will tell you if you're applying too much pressure. So don't be too timid and make sure that you apply enough pressure to reveal the aorta. One other common pitfall is shown right here, and it's really more of a misadventure of too much depth. You can see that the depth is set to 18 centimeters. At first glance, it looks like the person is measuring the aorta and it would be aneurysmal at 4.32 centimeters. But really what they're measuring is the anterior cortex of the vertebral body with the spine shadow. The aorta is located up here, which at first glance looks quite normal, and this would be the IVC. So make sure that your depth settings are not too much, and make sure that you carefully analyze your image and get oriented and clearly identify the aorta before you get your measurements. Once you've evaluated the aorta in short axis, it is worthwhile to do a long axis evaluation of the aorta. Again, remember, we're not taking measurements. This is just more of a qualitative evaluation. And what this sonographer has done is turn long axis on the aorta. We can see the anterior cortex of the vertebral bodies here. And this is the aorta. And you can see as the aorta moves more caudal, you can see it becomes more shallow. Here, the aorta is located at approximately 5 centimeters of depth, whereas here, the aorta is located at only 2 centimeters of depth. This is again why the distal aorta is more clearly visualized. Here we can see the celiac trunk, and this is the takeoff of the superior mesenteric artery. And we can see quite nicely that the aorta tapers, and we can also see that there's no clear intimal flaps to suggest aortic dissection, which we'll talk a little bit more about in a minute. This here is a nice video to demonstrate how to acquire the long axis image of the aorta.
To obtain the long axis of the aorta, turn your probe north-south on the body so that the dot is pointing towards the head. Here we see the aorta in long axis with the spine posterior. We can slide up and down the aorta and see the branches we saw in short axis. One of the most important views here is to find the celiac trunk and the SMA takeoff. Here we can look for lymphadenopathy and other pathology.
Okay, now we're going to look at some actual ultrasound video clips and images of abdominal aortic aneurysms. Now this image here is kind of interesting. You can see here clearly the abdominal aortic aneurysm. Here is the underlying anterior cortex of the vertebral body. But watch as I start the video, the aortic aneurysm disappears into the bowel gas. So you can see here a key point is illustrated. The abdominal aortic aneurysm, the most anterior surface of it, is only about 2 to 3 centimeters deep under the skin. So most large aortic aneurysms, even though bowel gas and body habitus are major limiters, if there is a large aortic aneurysm, oftentimes it'll reveal itself to you with minimal pressure. Now, I'm certainly not suggesting that if you cannot see the abdominal aorta, you can then therefore rule out aortic aneurysm. Not saying that at all. I'm just saying most of the time, if there is an aortic aneurysm, it will reveal itself. You may look at a patient and say, oh, they're too large, or you may initially start your exam and say there's too much bowel gas, I'm never going to say anything. Well, keep looking anyway. Most likely, if there is one there, it'll reveal itself to you. But again, don't rule it out if you don't find the aorta. Now this is the same abdominal aortic aneurysm, and they've turned long axis here, and you can see the spine here, and here is the aortic aneurysm, a nice fusiform aneurysm, and you can see that it tapers on either side, and the normal segments of the aorta are hidden in the bowel gas. So again, this illustrates quite nicely that the most anterior portion of the aortic aneurysm is only 2 to 3 centimeters of depth and is quite visible despite the fact there is a lot of bowel gas around this aortic aneurysm. Here's another image. We can see here the anterior cortex of the vertebral body, and here is the entire aortic aneurysm. Here we can see the true lumen with a mural thrombus, and we see actually a false lumen associated with it here. So if you were placing your measurements at the largest section of this aortic aneurysm, you would want to scroll through your image to approximately right here and measure from here to here, not here to here. Here's the same aortic aneurysm. Now we've turned the long axis. You can see the anterior cortex of the vertebral bodies. Here is the true lumen, and this is all mural thrombus here, here, and likely some element of a false lumen up here. Now, as I previously mentioned, this would be the appropriate location to measure this aneurysm. So as you can see right here, this is a 7.47 centimeter aortic aneurysm. There's another image. We can see right here the anterior cortex of the vertebral body. Therefore, assuming conventional probe orientation, this must be the aorta. So we slide along. We can see some mural thrombus that is moving with blood flow, likely true lumen, likely a false lumen up here. If you look very carefully, you can actually see what appears to be fluid outside the aorta here. Now it's possible this is also false lumen, but this could also be ruptured aortic aneurysm, likely rupturing into the retroperitoneal space. As we've discussed in other lectures, ultrasound is not a reliable tool to identify free fluid in the retroperitoneal space. So if you see this, then in all likelihood it has ruptured, but I would not expect to be able to see free fluid outside of an aortic aneurysm every time that it is ruptured. That's more of a clinical diagnosis. If the patient is toxic in appearance, hypotensive, has syncopized, or having flank pain or abdominal pain, you assume that this is a ruptured AAA, whether you see fluid outside the aorta or not. Now here's another image of a ruptured aortic aneurysm, and you can see the anterior cortex of the vertebral body. Here is the aorta here that is clearly aneurysmal, and you can see some free fluid out here. Again, likely a ruptured aortic aneurysm, but we're not depending on this image to confirm that diagnosis. So slide down, we see some fluid out here. Again, likely ruptured AAA. Okay, now we're going to transition from aortic aneurysm to aortic dissection. Now, over the years doing this, I've noticed that people often use aortic dissection and aortic aneurysm interchangeably. Now, aortic dissection can certainly coexist with aortic aneurysm, but understand they are not the same thing. So let's illustrate that now. Here we have the intima, the media, and the adventitia, and we have the blood flowing through the normal lumen of the aorta. Well, somehow, for some reason, there is a tear in the intima. And as the blood is rushing by, it starts to dissect between the intima and the adventitia. And you get this intimal flap that is waving in the flowing blood because the intimal layer has been dissected off the tunica media. This is an aortic dissection. Notice that the aortic diameter, however, is normal. Now, with regards to ultrasound evaluation for aortic dissection, we can certainly rule the diagnosis in, but you can see here that the sensitivity is only 67 to 80%. So you certainly cannot rule out the diagnosis. And as you'll see again here later, if you clinically think the patient has aortic dissection and the ultrasound is normal, you have to continue the workup with some other imaging modality. So this is what a aortic dissection looks like on ultrasound. Here we have the spine, the inferior vena cava, and this is the aorta at the level of the SMA takeoff. And you can see this small flap, this intimal flap, that is dissected off of the wall of the aorta and flapping as the blood flows by. Now here's the corresponding CAT scan image for the same patient. You can see this aortic dissection here. Now here is the same patient with the video clip. That with each beat, there is an oscillation of that intimal flap as the blood rushes by. And you can see actually this intimal flap is dissecting up into the superior mesenteric artery. Here's another one. You can see initially that the aorta looks fairly normal, but as we slide down, there is the SMA. We see an intimal flap right here. Now take note, the aortic diameter is normal in appearance. Also, hopefully you're thinking to yourself that this would be quite easy to miss. And in fact, it is quite easy to miss an aortic dissection on ultrasound. As we mentioned briefly a moment ago, the sensitivity is quite poor, and this is a reason that I was saying that if you clinically think the patient has this diagnosis, you have to advance to other imaging modalities. Here's another case. This is a aorta in long axis, and you can see an intimal flap right here, oscillating as the blood is flowing by. This is again consistent with aortic dissection. Now bear in mind, the management of aortic dissection depends on the origin of that aortic dissection. If the aortic dissection originates from the ascending aorta, then this is a surgical disease. However, if the aortic dissection originates from the descending aorta, then by and large it's usually a medical management disease. This is, of course, assuming that the dissection doesn't involve any major organs or the patient is not unstable. Now, with ultrasound, you can evaluate the thoracic aorta to some degree. Now, in this case, you can see the aortic outflow tract, the aortic valve, and the aortic root with the ascending thoracic aorta. You can also see a small portion of the descending thoracic aorta here. So if you have a patient who has an aortic dissection, you could start off with a parasternal long axis view of the heart and look to see if you can see any clear intimal flaps. If you see an intimal flap here, then you know that this is a type A aortic dissection, an aortic dissection that is going to require surgical management. Another way that you can evaluate for ascending aorta involvement of aortic dissection is to actually measure the ascending aorta. This is what we've done here. You'll get your parasternal long axis view of the heart, and you'll freeze the frame with the aortic valve leaflets open, and you'll measure across the ascending aorta as seen here. And the normal diameter is less than 3.6 centimeters. Anything over that is consistent with a dilated ascending thoracic aorta. If the patient has a confirmed aortic dissection at another location, say the descending thoracic aorta or the abdominal aorta, then this would be highly concerning for concomitant involvement of the ascending thoracic aorta. Now, a dilated aortic root greater than 3.6 centimeters certainly does not confirm the diagnosis of aortic dissection. It could also just be an aortic aneurysm involving the ascending aorta. Now, another way that you can evaluate the ascending aorta as well as the aortic arch is to try the suprasternal aortic arch view. And this video and image was supplied courtesy of Dr. Hampton. You can see here we've taken the cardiac probe or phase array probe. It's been placed in the jugular notch with the probe indicator pointing away from your point of view to the patient's left scapula. The back side of the probe is fanned towards the patient's chin, and you should see the aortic arch as seen here. Here is the ascending aorta, aortic arch, descending thoracic aorta. This is just for point of reference, the right pulmonary artery. And we can see right here the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. And you could take a look here and look for any intimal flaps that are coming through this area. When you're trying to acquire this view, it's often helpful to put a shoulder roll in between the patient's shoulder blades to displace the chest in an anterior direction. Now, as I mentioned, the management depends on the origin of the dissection. And we can evaluate the pericardium, the aortic root, and aortic arch to see if there's any ascending aortic involvement. The reason I mentioned the pericardium is because if the aortic dissection does come back and involve the aortic root, sometimes you'll get seepage of blood into the pericardium that can go on to develop pericardial tamponade. If this patient isn't rapidly repaired, then certainly death is imminent. In fact, these patients have a very high mortality rate. But regardless, you can look for subtle clues of aortic dissection involving the ascending aorta by evaluating the pericardium. As I previously mentioned, most of the time you're going to have to advance to CT or transesophageal echo or TE. And most of the time you're going to do this because, again, management critically depends upon its origin as well as what organs the aortic dissection involves, and the vascular surgeon needs to make plans on how they're actually going to repair the aorta. So most of the time you're going to be getting advanced imaging of these cases. Another limitation of ultrasound evaluation for aortic dissection is it's very difficult to tell acute versus chronic. I myself have seen a couple of patients who present with chest pain. We do a bedside ultrasound and discover an intimal flap consistent with dissection, but it later turns out that this was actually chronic and the patient didn't know it. So it can be quite difficult to tell the difference between acute and chronic aortic dissection. So overall, bedside ultrasound for aortic dissection has value. If you see a flap, they likely have the diagnosis. You can go ahead and initiate the management before definitive testing. But again, most of the time, you're going to ultimately be getting advanced imaging. And the biggest take-home point of all with point-of-care ultrasound for the evaluation of aortic dissection is do not use ultrasound to rule out aortic dissection. You clinically think they have the diagnosis, you have to get advanced imaging, usually CT angiogram. Now let's talk about some pearls and pitfalls for bedside ultrasound evaluation for aortic pathology. As we mentioned, bowel gas and body habitus are major limitations. These can usually be overcome with direct pressure on the ultrasound probe. Saccular aneurysms are less common, and they are usually quite easily overlooked, but they also are more common to rupture. So if you have any doubt, go ahead and send these patients either for CT or formal radiology ultrasound to evaluation for saccular aneurysms. Always remember, aneurysms 4 to 5 centimeters do rupture too, although the cutoff for elective repair is 5.5 centimeters, or aneurysms that are expanding greater than 6 millimeters per year. But as you recall from our chart earlier, the rupture rate of 4 to 5 centimeters was not 0%. So if you have a patient who presents with a 4.5 centimeter aneurysm, but clinically they seem as though they have a ruptured aortic aneurysm, treat them as such. Remember to measure outer wall to get the most accurate measurement of your aortic aneurysm diameter. Most AAAs rupture into the retroperitoneum. Do not expect to see intraperitoneal fluid, and on the same token, do not expect to see free fluid in the retroperitoneal space either. Clinically, if they seem to have a ruptured AAA, treat them as such. Measure the diameter in a transverse plane perpendicular to the wall. Again, remember, if you have tilts on the probe, either towards the feet or towards the head, this will falsely enlarge the aortic diameter. And if you measure in long axis, you may run into false narrowing of the aorta due to cylinder tangent effect. 40% of distal aneurysms extend to the common iliacs. Make sure that you scan the common iliacs in a patient who has a AAA. Also, make sure that your conventional probe orientation is used all the time, and this will help you prevent from mistaking the IVC for the aorta and vice versa. Make sure that you adjust your gain to the proper settings. If you overgain, it's very difficult to tell where the aortic wall ends and begins. And again, aortic dissection is very easily overlooked. So I hope you enjoyed the talk on ultrasound evaluation for abdominal aortic aneurysm as well as dissection. If you have any questions, I can be reached at this email here.